CMI CPDX research webinar. We have had 26 webinars of this kind earlier, and this is an exciting, interesting project we have today, a paper presented on healthcare. And we have had a couple of papers on health, but this is unique. This is very different and promises to be really particularly very interesting. So this is a paper which is being presented by Somdeep Chatterjee of IIM Calcutta. The paper, as the heading goes here, is Healthcare a Normal Good for Women in Developing Countries. The paper has been written by Subhangi Agarwal, Chirantan Chatterjee, and Somdeep Chatterjee. Subhangi Agarwal is from IIM Ahmedabad. Chirantan Chatterjee is from University of Sussex Business School. And Somdeep is Assistant Professor of Economics at IIM Calcutta. His interests are in development economics, and he will be making the presentation today. We also have with us Aparajita Dasgupta, Assistant Professor of Economics at Ashoka University. She is the discussant for the paper being presented by Somdeep, and we will listen to her after Somdeep's presentation. So Somdeep, you have 1 hour to make your presentation, and Aparajita, then you have half an hour for your comments on the paper. Audience who have joined in will join in, are free to ask questions on the way, and Somdeep will be happy to answer them. You can ask your questions by typing in those questions in the Q&A box over here, and Somdeep will either answer you at runtime or very likely at the end of the show. And the same thing happens for Aparajita's presentation as well. So I won't take up much of this time. We are here to hear the authors and the discussants. So I'll hand over to Somdeep. Over to you, Somdeep.
Thank you very much, Mahesh, for the very kind introduction, and thank you very much for inviting me to this talk. It's a real pleasure to be giving this talk at CMI, particularly because we are using your flagship data set, right, the CPHS. So we had a lot of fun using the data. We are supplementing it with another data set, as we'll figure out how we are when I talk more about this research. So let me dive in, as you rightly pointed out. So this is co-authored work with Subhangi Agarwal, who is an RA at IIM Ahmedabad, and Chirantan Chatterjee, who is at the Science Policy Research Unit at the University of Sussex. So let me get to the context of the paper. Right. If I could get are my slides moving, by the way? Yeah.
Yes, they are.
Thank you very much. Thank you. So the relationship between income and healthcare has always been a very important aspect in understanding the role of human capital in developing country contexts. So this has been widely studied in the health economics literature, particularly in developing countries as well. Now, there's a huge body of work which tries to estimate the income elasticity of demand for healthcare, right? Many of these studies actually find that the income elasticity of the demand is less than 1 empirically, which suggests that healthcare is a necessity in these particular contexts. However, earlier literature used to find that healthcare seems to be a luxury good. So they find that the estimates of income elasticity of demand for healthcare as the good is actually greater than 1. Now, what explains this heterogeneity? Why do we have this kind of heterogeneity? There are, again, 2 schools of thoughts based on how we can think about this heterogeneity. The first is that it could be heterogeneous depending on the level of development of the country that is being studied. So are we talking about a country that is much more advanced? Are we talking about a country that is a developing country? Is it a less developed country? So depending on the context of the study, these elasticities may actually vary. Similarly, another body of work talks about the fact that this elasticity may actually vary based on the level of analysis, right? So whether you are actually looking at micro level of elasticities. So for instance, if you're interested in understanding the income shocks to individuals, then estimate the change in demand for these individuals, then that is the micro level study where you can estimate the elasticity, as opposed to a more macroeconomic study where you say that, okay, what is the response to GDP when there's an increase in healthcare spending or something like that. So that would be a relationship between income and health at the country level. In this paper, actually, what we're interested in doing is exploring another source of heterogeneity, which is much less studied, interestingly, and that is estimates of income elasticity of the demand for healthcare based on gender-based tastes and preferences, right? Now, why is it important? Again, I think the most important body of work here is represented by the work that Paceline Dupa and Radhika Jain have been doing, particularly when they show that households seem to allocate more resources to males than females, particularly in terms of utilization of healthcare, as well as they document that there's gender inequality in access to healthcare. So that's sort of a starting motivation. And then we are actually wanting to explore what happens to potential relationship between income and health. A broader motivation for this study could be from a very standard development economics question, which is what happens when you provide money in the hands of people, right? So this would be the literature which talks about responses to transfers received. Now, this literature very clearly documents the role of gender identity. So we know that the gender identity of the recipient matters. So body of work by Banerjee, Duflo, Goodman and Kaplan, again also Dupa and Chen, who show that the gender identity of the recipient is important, particularly when you think of major anti-poverty programs in developing countries. These are particularly targeted towards women, right? So you could think about transfer payments that are made to women. And why is it important? Why are these made to women? Because literature suggests that this increases the assertiveness in the household decision making, which deals with expenditure allocations. It has a positive impact on the nutritional status of the household. It can positively affect household human capital investment decisions and negatively impact on consumption of intoxicants. So these are like positive welfare effects or positive consequences of giving money directly to women. So of course, this does tell us that in the developing country context, women behave differently compared to men when they get money in their hands. So this is the literature on transfer payments, particularly. However, you might say that, well, transfer payments are very distinct compared to shocks to earned income. What happens when earned income of the women changes? Do they respond in a similar manner? Do they respond differently? And are their behaviors actually different from what we would expect from standard males' behaviors, right? So that's, again, documented in the literature, particularly the works by David Otter, as well as Mackenzie, Osler, and Baird. So in this paper, our estimates are going to give you direct impacts of an increase in the disposable incomes of women in formal employment. And then we're going to estimate the impact on healthcare demand, right? So that's the channel that we are interested in. Of course, to be able to identify this, we would need an exogenous shock to income. How do we exploit this exogenous shock to income? We are taking advantage of the change in the mandated rates of provident fund contributions. So the take-home salary of women in formal sector is essentially dependent on the deductions that happen to your salary, right? Now, on February 1, 2018, the government of India came out with a policy change. What was the policy change? The policy change was women workers joining the formal sector would now have a mandated contribution of only 8% as opposed to 12% previously. So the employee's contribution to the provident fund was actually reduced. Now, this implies that there is a direct change or exogenous shock to the disposable income, right? Of course, in the long run, it might matter very differently because eventually your lifetime savings are changed and so on and so forth. But this is a short-run analysis, basically. So in the short run, what is happening is that there's an increase in income. So essentially, this is an exogenous shock to income, which has got nothing to do with healthcare spending. And using this exogenous shock to income, we're interested in estimating the impact on healthcare demand. So that's roughly the premise of this particular paper. The idea, again, is that this is not a transfer payment coming from the government for a development scheme. This is actual earned income. So how does the woman decide how to allocate this additional income? Is that showing up as a negative impact on healthcare or a positive impact on healthcare? So that is the story that we're after. What do we find? Just to give you some spoilers right away, we're going to show you that this results in lower healthcare spending in response to this particular income shock. Now, this suggests that there's a potential negative income elasticity of healthcare demand. Now, why is this interesting? We're going to come to that, and what is the logic that we have for this particular finding. However, there's one thing that I want to point out right at this point, which is that we are able to analyze the intensive margin of healthcare as opposed to many other studies which are able to only study the extensive margin of healthcare. Now, what do I mean by the intensive versus extensive margin? The extensive margin of healthcare would be whether or not a woman has an access to hospital or hospital care. Here, other than the CPHS data, we are also going to be using administrative data from hospital medical records, which means that conditional on getting hospital care, do we actually observe changes? So that is the intensive margin of healthcare that we're interested in. And because we're able to analyze the intensive margin of healthcare, we think we are able to do a little better in terms of actually identifying the effects, particularly in terms of this negative income elasticity, which has not been documented in the literature so far, which has largely focused on extensive margins. Because unless you have this administrative data, it is very difficult to actually get at the intensive margin. All right, so let me first talk about the conceptual background, because I told you what the result is going to be, and I'll show you how we get to the results and how robust the results are. That is coming a little later. But right now, let me just give you the conceptual background that we have for this paper, which sort of builds up a premise for the finding. From Dirac, Potoms, and Tomazzi, a very recent EDCC paper that came out. They are studying a household collective decision-making model in response to public policies. So in their paper, they show that the impact of a cash transfer is indicative of a change in preferences over and above the income effect. So essentially, again, not going into the math and the model of the paper, the crux of their paper is that, well, over and above an income effect, when there's an income shock, and this is in the context of a transfer payment, mind you, when there's a shock to women's incomes, the preference pattern might change, right? Now, remember, when we are estimating elasticities, when we're looking at these comparative statics as to what happens when there's an increase in income, what happens to demand, so on and so forth, we're essentially making a ceteris paribus assumption, right? So we are kind of assuming that everything else is constant, particularly preferences are constant, and then we are trying to estimate. But if we allow preferences to change, that would essentially mean that the household actually has to re-optimize. So if the preference pattern is changed by a shock, then the household is re-optimizing. So in that case, it is not surprising if you find very different effects later on when you're re-optimizing. So that's the first premise for motivating these results. Dirac, Potoms, and Tomazzi also show that this is particularly true for what they call secondary effects. That is, if women have skewed preferences towards consumption of certain types. So let's imagine in the household setting, women has a preference ordering over 4 different commodities, let's say A, B, C, and D. And if they have a very strong ranking, then it's not necessarily true, perhaps, that if there's an increase in income, all these 4 would go up. Because if they really prefer A over all the other commodities, then they might want to increase A and neglect B, C, and D. So that's roughly the idea. So in our context, this would mean that if your preferences towards your own healthcare is not very high up the pecking order, if you care about other types of consumptions, then this income shock might be absorbed by the other preferences, other more preferred consumption commodities, not just healthcare, and therefore healthcare can actually also be neglected. So that's roughly the idea that we have. The second theoretical insight that we want to point out here is that if women have a strong preference towards contributing to the household public good, which again is very true in a developing country context like India, right? That the women is disproportionately expected more to contribute to the household public good. That's sort of unfortunate in the setting, but that's how our societal structure is. But if that is the core structure of a majority of Indian households, then this may mean that a marginal increase in their income may not directly lead to an increase in individual consumption expenditures. Particularly with shifting preferences, this can actually also lead to a decline in expenditure in favor of something more preferred, right? So if you have a less preferred consumption expenditure, that might actually go down. The final point that I want to make here is that women's preferences may rank healthcare expenditure lower, as I was trying to point out earlier on, and other consumption higher in the preference ordering. Now, this could be true because of re-optimization, but this could also be true if you have other social factors, which are again very relevant in the Indian context and in many other sub-Saharan African or other developing country contexts as well. And Anukriti has a body of work which talks about a lot of these social factors or societal pressures. For instance, family and peer pressure in the households in developing countries. Right? So whether you're living, cohabiting with your parents-in-law, and then sometimes you have certain social norms which dictate how you're making allocations to the household public good, right? So in that case, if these social factors are also relevant, in that case, it might so happen that if healthcare is ranked fairly low, then an increase in income might not directly reflect in an increase in healthcare demand. The final piece of evidence that or final body of evidence that I want to talk about here is that households are non-unitary, and small transfers to women may often be appropriated by men and diverted for other purposes. So this has also been widely established. So that might also be happening. If you have very skewed bargaining powers within the household, then an increase in income does not necessarily mean that the woman is able to spend it on more preferred commodities, if there is appropriation by the male member of the household. All right, so that's roughly the theoretical premise without going into a lot of model, because we don't do any theory in our paper either. We just borrow from existing theoretical papers. I want to talk about the empirical specification. Now we have two different empirical specifications because we are using two different empirical data sets, but they are largely similar. It's just that to suit the nature of the data or the structure of the data set, we have to make certain tweaks, and I'll talk about them. But basic identification strategy remains the same. So let's look at this particular equation that I'm currently showing you on this slide. So YHM is the outcome variable that we are interested in. This is at the household month level, and it's measured in logs. The coefficient of interest here is beta 3. We're interested in beta 3, which is an interaction of two other dummy variables. The first dummy variable is beneficiary, which is going to equal 1 when a female household has been predominantly classified into the occupation group of formal sector pre-February 18. Why pre-February 18? Because in February 18, the announcement was made for the change in EPF. So we are just looking at pre-February 18. If the household has been predominantly classified in the occupation group of formal sector, so that is going to be classified as a beneficiary household, and 0 otherwise, if they have been classified in the non-formal sector. And post-February 18 is a simple time dummy, which just takes the value 1 if the observation comes from a month after February 2018. We have controls for age, education, household size, and we also have month and household fixed effects in the specification. For this particular specification, we are using the data set for which I am here, which is the CPHS, right? So we obtain data on monthly consumption expenditure on Indian households between January 16 and February 20. This happens to be the world's largest panel survey. Correct me if I'm wrong. And again, I don't need to talk a lot about this data set because most of us are familiar with it, but I'll just point out what I'm using from this data set. The main outcome variable that we're interested in is monthly expenditure of households on total healthcare, and this is measured in logs. Other healthcare outcomes to study division of budget across different categories. Is there a question somewhere? So yeah, there's a question. I'll take the question. So Aposhik Banerjee is asking, are you able to identify which mechanism out of the ones you discussed that make healthcare spending go down as women's take-home salary increases is more likely happening in the data you analyze? So that's a very good question, but unfortunately we are not able to pin down channels, particularly because we don't observe a lot of those things. Because again, observing how the household internally optimizes is very, very difficult. So that's not something we are able to do. So at this moment, it's just conjecture. But again, if anyone has suggestions on what kind of data set might actually help us pin down some of the channels, that'd be great. But it's a very good question and a point well taken. So yeah, right now we are not able to do that, which is why we have to look at the results with caution. It's essentially very reduced form findings. It's like an intent to treat sort of effect. There's a policy and there's an effect of that policy, which we observe. We have certain conjectures. Based on our analysis, we fail to reject some of those conjectures, right? But that does not necessarily mean we're able to pin down the conjecture. That's the stance. That's at best what we can do given our analysis. But yeah, beyond that is not really possible with our data set. Okay. I don't know. I lost control of the slides. Right. Okay. So other goods and services as outcomes to examine the income allocation. So we look at 15 categories, including food, clothing, intoxicants, education, etc. So the nature of the data actually allows us to capture the effect of the intervention on the targeted group, because CPHS, as we all know, captures demographic indicators of the household as well, particularly gender, age, occupation, education, and family size. So to capture the true nature of decision-making of the women in a household, we identify the sample of households that have more female members than male members. So that is going to be based on the gender groups in the CPHS. So maybe I might as well want to show you this. So we study female households, as I said, and among female households, we have various categories. So female-dominated households, as I said, that our first in our baseline specification, the beneficiary is going to be female-dominated. So what do we mean by a female-dominated household? Formal sector. So the female-dominated households, our number of females is more than males, but not more than twice. Female majority, number of females are twice the number of males, and only female households are households which does not have any male members, and we have male member households as well as balanced gender households. In the occupation group, so this is where we actually use the beneficiary, formal sector. So the formal sector is classified as these employment categories in the CPHS, and the other categories have been classified as non-formal sector. However, we change these classifications as well for robustness. So we include some of the other things into the formal sector and see if results change. Some of these categories which we feel may not necessarily be formal sectors are removed, and we try out with it by classifying them as non-formal sector. But the results are fairly robust, so the result does not depend on this classification. That's the main point. So to avoid sample selection bias, we follow only those households in the panel for which we have a response beginning January 2016. So we obtain the data on monthly consumption expenditure on Indian households between January 16 and Feb 20. Oh, I think I have already talked about this. So there's some issue with my slide. I don't know why the slides are not moving in the right direction. Okay. Right. So now I'm going to show you, before I show you the results, I want to show you the second empirical specification. Again, the identification is very similar. Remember, the identification in the previous setup is coming from the comparison of formal households or households which have predominant formal employment versus informal households, female households, and then we are comparing before and after. We're going to do the same here, just that instead of households, here we are able to look at the individual, because this is more individual level data. So this is going to come from the hospital medical records. I'll mention the data set in a second, but I'll first show you the specification. Again, very similar specification as you see. Beta 3 is the coefficient of interest, which is the interaction of those two dummy variables, beneficiary and post February 18. The only difference is here beneficiary takes the value 1 if the female patient that is visiting the hospital is employed in the formal sector, as opposed to trying to classify as predominant households, formal sector households, and so on. We also have center, state, and time fixed effects in this specification. Again, does not affect the results that much. There's a very interesting thing that we're able to do, and that is one of the reasons why we need to supplement the CPHS with this data set. Because CPHS will not allow us to actually control for disease conditions. Because one of the criticisms that you might think of is, okay, if women with higher income are healthier, it's only natural that they would not spend more on healthcare, right? So they are probably healthier anyway. And there's a big body of literature which says that yes, income leads to better health. So if women are having better health, then why would they spend on hospital care, right? So here, because we are actually using inpatient data, people who are actually admitted into the hospital for some medical treatment, we are able to control for the disease condition. Because this is eye hospital data, what we control for is visual acuity. I'll talk about that in a second. So that means essentially we are able to compare women with similar health and then look at differences between formal and informal sector before and after, right? So we are able to address that problem here. The same issue persists. I don't know. Okay, so here we examine how women spend on healthcare, conditional on accessing healthcare using what is called the iSmart data. So this is coming from the LV Prasad Eye Institute administrative data, electronic medical records of 5.9 lakh patients that have visited this hospital. So we again in order to avoid contamination from COVID effects and to be consistent with our CPHS analysis, we look at the data from January 2016 to February 2020. We have expenditure on healthcare that is measured by two primary outcomes. One is the investigation amount that the individual spends and the surgery amount. Additional outcome that we have is on out-of-pocket expenditure, which is the difference between the price of the healthcare, that is the surgery amount, and the financial assistance received. This is important because what we are interested in is actually the out-of-pocket expenditure, because you might say that, oh, insurance might also vary depending on income, and that might explain some of your findings, essentially. There's a question from Sujata Balasubramanian. Let me take that question. Is there a classification of enterprises as formal, informal, such that formal enterprises have to provide EPF benefits to their employees? Are your formal workers part of these employees? For the first part of the question, I'm sure there is, although off the top of my head, I don't remember right now, but I agree I should. The second part of the question is, are your formal workers part of these enterprises? I think that is difficult to measure, so we'll not know from either data set, I think. Definitely not from the LV Prasad data set, because that's where we only know, because this is basically a sheet that is given to them and they have to mention their occupation, but which enterprise they are working for and whether that enterprise is actually mandated to provide EPF or not sure about that. And that's very difficult to do, because in India, if among a lot of things that we have, the thing that we do not have, and I think a lot of labor economists are waiting for it, is matched employer-employee data. So we really don't know where people work, and we are not able to link, because if that's another gold mine if that exists somewhere, because a lot of these questions are answered using linked employer-employee data sets, which are available in Europe and also in the US. Sujata Balasubramanian has a follow-up question. How do you know your formal workers are covered by the EPF rules? Well, I do not know if all the formal workers are covered by the EPF rules, but I know for sure that the informal workers are not. And I know for sure that anyone who is covered by EPF rules must be a formal sector worker, right? So yes, this might mean that some of our estimates are just underestimates, right? So that would basically downward bias some of our findings. So yeah, so whatever point estimates I'll show you, the actual effect, the true effect might be a little larger than that. That's all it means. Akoshik Banerjee has another question. Do you have a good mix of diseases or a particular kind of diseases that are being treated for the women who have hospital records? Yes, we have different types of treatment that we observe, but these are eye hospitals, so they are all related to the eye. But yes, we do observe different types of surgeries, different types of procedures, whether it's a cosmetic surgery, whether it's an emergency surgery, whether it's a cataract surgery, all of that we observe. But if you have anything specific in mind, we can come back to that later on. That shouldn't bias anything that we're doing right now. Okay. So again, this data also allows us to identify the gender, age, marital status, occupation, disease condition, and measure of visual acuity of a patient. So visual acuity is basically the pre-existing disease condition that we're going to use. So essentially, when every patient is coming in, their visual acuity is measured. That means how much vision they have in their eye. So that's a technical measure that they use, and we have that data with us. So basically, we throw it in as a control. The moment we throw it in as a control, we are able to compare individuals who have similar eye conditions. So that's the way to sort of address the issue that they have different eye conditions. A female visitor at the hospital is classified as a beneficiary if she's employed in government or private service. Oh no, again, I'm very sorry, there's some issue with the slides. It keeps going back to the maybe because this is a CPHS seminar, it keeps going back to the CPHS. I don't know what you have done here, but somehow it works. Anyway, so I'll show you some findings here. So the first thing that I want to show you is the pre-trend for the main outcome of interest, which is health expenditure. And we're going to compare the treatment and the control group. So this is the slide, and this is coming from our CPHS analysis. So if you look at the total health expenditure of the households, you can see before the policy was implemented, these differences between beneficiary households and non-beneficiary households, keeping the first quarter of 2016 as the excluded quarter, if you compare, there seems to be no real difference. But after the program, you can see, after this EPF, you can see that the healthcare expenditure sort of not only declines, there's a marked decline that we can observe, but also these estimates start becoming significant, right? So that's the event study plot using the CPHS. What else do I want to show you? Maybe some of the sample means from the hospital system data. So again, the sample means from the hospital treatment data is also very, very similar, depending on whether they are beneficiary or non-beneficiary households. And these are some of the types of visual acuity measures that we have. And they're not very different across these beneficiary and non-beneficiary classifications. Let me move on to the next slide. So the first set of results that I want to show you, again from the CPHS, is the health expenditure. So you can see that the impact of this particular EPF mandate is negative on health expenditure. So health expenditure significantly goes down. These are in logs. So we have controls and fixed effects. So column 4 is our most preferred specification because it has all the robust fixed effects and controls that we are actually interested in. So this roughly corresponds to an 11% decline. Change in expenditure on associated healthcare variables. So this is coming from CPHs again. If you look at doctor fees, medicines, hospital fees, you can see that there is some substitution, that health enhancement expenditures are sort of going up. Health enhancement are like where individuals are spending to have better health quality, which is again, this is coming from the CPHS. This sort of suggests that, well, this might mean that there could be impacts on health, and therefore, because women are now investing in their own health, they have better health, and therefore they spend lower on medicines and doctors' fees, right? So that is why we needed to supplement it with the hospital data. Otherwise, we were finding what we were able to test the main hypothesis using CPHS, but the reason for the different data set is precisely coming out of this particular table. Okay, a change in other goods and services, you can see that the regular ones do matter. So for instance, education, yes, women do spend on education. Women do spend more on power fuel, right? Women, however, spend less on restaurants or other types of spending. So essentially, human capital investments are going up, more environment-friendly consumption, those are going up. So these are just substitution effects that we were interested in finding, that what happens to other types of consumption expenditures, because we see that healthcare expenditure is going down. But however, there's no way to really map it back to the preferences to know what the pecking order of preferences is coming out of that Dirac-Bottoms model. We would have loved to have done that, but that's not really possible given our reduced form specification. For that, you'd need more structure. We also do this change in health expenditure as a share of income to try and understand how big these effects are, because sometimes you might think that, okay, it seems more arbitrary that, okay, this is directly a reduction in healthcare. So now we are actually presenting our findings in a more relatable magnitude. So you can actually see that as a share of income, the change in health expenditure is about 0.001. So it's not as big a change actually compared to how much income now you are having more. All right, some robustness checks from this data set. So what we do is we also look at the extended period. So instead of just, because we said that we are concerned about contamination by COVID, so we just looked at Feb 2020, but CPHS was available beyond that. So we looked at that. Results are robust. So that 11% becomes about 12%. So it's not very different. So now again, because we cited in our motivation that there could be male appropriation. So one of the things that you might wonder is, okay, so even if these are female dominated households, there might be a very dominant male in the household who decides how the allocation is going to be done. So what we did then is, okay, so why not let's focus on simply female households, right? So we just focus on female households, only female households who have no male members. And even there we find effects. In fact, we find much larger effects, right? But doing this is again problematic in one way, because there's a large literature which says that, okay, household composition is endogenous to income, right? So again, depending on income shocks, your household composition might change, whether you have a female dominated or a male dominated or household structure. So that opens a different can of worms. what we do to avoid that issue is show you this sample selection issue that, okay, the household composition. So this is the dummy of female households, and we run it on the specification. So because of this policy change, at least household composition is not changing, right? So we are reasonably comfortable with the analysis that, okay, we can look at female households separately and we can look at female dominated households. So that doesn't really matter. The policy does not affect that. We looked at households that were predominantly classified as formal sector households before the policy. Again, you might think that, well, the policy might affect some of these things, whether this is a good way to define the treatment or not. So we try various alternative types of treatment. I'll show you a couple here. One is, instead of looking at predominantly formal, we look at if the household is formal at least once in the pre-period. Very similar results, nothing changes. We look at households which are formal consistently throughout. So their definition of whether they're a formal sector household or informal sector household does not change at all in the data set. Even there we find exactly the same point estimate, basically, right? It's 11 and 10%, so it's not very different. All right, so now I want to show you in the final couple of slides, results from the hospital data set. So here we are actually looking at investigation amount and out-of-pocket expenditure. So this third row here is the relevant row. Sorry, I should have made it the first row. I keep forgetting. So the third row is the relevant row. You can see that there's no impact on the investigation amount because, you know, how much you spend on investigation, that does not change. What changes is when you are prescribed surgery. So female households or female employees working in formal sectors seem to be actually affected, that they prefer to push back on the surgery. And this entire effect comes from the out-of-pocket expenditure, as you can see here. We also look at the sample without insurance, and there's no effect at all on the sample of insurance. So the exact same estimate is coming out for surgery, which is entirely driven by the out-of-pocket expenditure. So insurance does not really matter here. Now, one way to think about this could be potentially that women are holding back for some other expenditure. Maybe this is a lumpiness story that, you know, sometimes surgery requires a lumpier investment. So maybe if you have a small increase in your income, you're sort of piling on money and you're pushing back, you're delaying your surgery, you're spending less now with the hope that you'll spend eventually. All that might be true, but what matters is this does not happen for the male households. This only happens for the female households. So there is something interesting that's happening, right? So that's the gender story that we are coming up with. We also look at the married sample and whether expenditure across surgery types vary. So this was, again, a question that Akushik had. So these are the types of diseases that we have, whether it's an anterior segment, it's cataract, cornea, glaucoma, strabismus, trauma, oculoplasty, or a refractive surgery. We have very similar effects all throughout, actually. So not much to talk about there. All right, so I'll conclude and then leave with some speculative thoughts, and then I'll be very happy to take more questions and also to hear the views of the discussant. So while existing literature concludes that healthcare is a normal good with positive elasticities, so there is a debate on whether it's a necessity versus whether it's a luxury. That means within the classification of a normal good, whether the elasticity is greater or less than 1. We actually come out with novel evidence which suggests that, well, it's not necessarily that it is always a normal good. In certain contexts, we might find a non-normal relationship as well, and this is a developing economic context. While the obvious challenge for this result could be that, well, women have better health outcomes due to higher income, but at the intensive margin, I just showed you that the selection into better health outcomes does not necessarily drive our average estimates because we are able to control for health condition. And controlling on health condition, the result still goes. So this must tell you, this must mean that there is some kind of inequality in utilization of healthcare that is happening. So what is the discussion and speculative thought that I want to leave this presentation with? So we conjecture that women's preferences in developing countries for household budget allocations are strongly driven by social and cultural norms. So a marginal increase in the income of a male member in the household is not necessarily treated in the same way as a marginal increase in the income of a female member of the household, right? So if this is the social structure, then whatever we find seems to be very plausible, right? The idea is that this ironically also means that you're actually ending up contributing to healthcare expenses of other members in the family rather than the individual herself. So for instance, if a women earning member of the household who is living in a patriarchal family structure might be required to contribute to maybe an elderly male's eye treatment or cataract surgery rather than her own eye care surgery, right? So if you have an increase in income. So that's how you might be disproportionately required to contribute more to the household public good rather than your own individual consumption. And if this might be true, then the regular normal good relation will not hold. So that's this paper. I think I've finished 15 minutes or so before time. So I'm happy to take questions and hear the thoughts of the discussant. Thank you very much for this opportunity.
Thank you very much, Somdeep. That was an excellent presentation.
Thank you.
I thoroughly enjoyed watching the entire thing as you went ahead breathtakingly. But I can assure you the uncanny movement back into the CPHS slides was none of our doing. This just happened. So not just because you're in a CPHS webinar.
It was just meant to be, I guess so.
Okay. So, but no, wonderful presentation. You have one question, I guess. There's some questions which has come up. A couple of them, actually.
Okay, I'll take those questions. So are there separate results for currently married women for general household expenditure categories that might reveal some of the intra-household bargaining issues? Sujata Balasubramaniam, very much on point. We exactly find that. I'm not going to push that finding a lot, precisely because that's a companion paper that we have, where we actually look at what happens to the marriage market and marriageable age category women. But yes, in this paper, we do show that for a married sample, the effects are more pronounced. Right. So yes, so that does allude to some of the intra-household bargaining issues, but we won't push that channel quite a lot here. Okay, Akorshik again, I guess. Among the different surgery expenditures, do you see treatment effect for diseases that are more pressing or less pressing due to power dynamics of women? Okay, yeah, again, so another companion paper. So we are not going to talk a lot about that because that's not the paper that I'm discussing today, but I'll just give you some idea about what we do seem to find. It is true that women, of course, if these are pressing surgeries, the effects are much less pronounced. Of course, they're quite dampened. If these are elective surgeries, so the effects are mostly driven by the elective surgeries, which you can potentially push back. But it turns out that for these elective surgeries, when you can push back some of these surgeries, the males do not push it back as much as the women are pushing back. So that's the discrimination or the inequality that we actually observe. However, as I said, when we are in the marriage market paper that we have, we actually see that for marriageable age category, some of these elective surgeries are also now more preferred by women, potentially because that leads to marriage market returns. Right? So that's there. So it's an interaction of these two. Pinaki Banerjee has a question which I think I have already answered.
Great. Thank you so much. There's one more by Meghna Padmanabhan.
Okay, Meghna and Forum. Okay. So Meghna, would you expect similar preferences for allocation towards women's health when the household receives a transfer? For example, a means-tested health insurance program? Well, I think the premise of the paper was that the answer to this is no. We'll expect to have very different types of results. But it turns out that there's one thing that is common. So in general, when you have these means-tested transfers, you do seem that women are more efficient in terms of the household production or creating more value to the household. Unfortunately, that has a flip side to it here. So that is precisely what is happening here as well. But this is your own earned income. So this is not an income that is meant for you to manage, but this is an income which is supposed to be your own disposable income. The concern that we have is that even for this disposable income, that is being disproportionately perhaps contributed to household production. Right? So that is where this gender inequality thing is coming from, which may not be the case for males. I don't know if I probably didn't show you those results. For the male households, we do not find those effects at all. Okay, Forum has this question. Since eye care was taken, preferences may get affected by working hours on screen, while few women have less screen timing that may affect the need for eye care, while the ones, well, that's true, but the fact that we are using the hospital records data sort of alleviates this concern. Because the only reason why you show up in this data set must be because you have some kind of ailment. Remember, this is not OPD data. If it is outpatient data, that might be very, very different. But because this is inpatient data, you are admitted to the hospital. If you're admitted to the hospital, it has got to be for some ailment, right? So that is one of the reasons why we use this data set to supplement the great CPHS analysis that we were able to actually put together. The CPHS analysis, of course, is much richer because it allows us to do various other things, including the event study sort of analysis, which we are not able to do using the iSmart data. The only advantage of getting the iSmart data is this intensive margin story and being able to control for health status, sorry.
One of the things that is most gratifying to us at CMI, Somdeep, with your work, is that one of the purposes of doing this survey, CPHS, is to enable event studies. So therefore, the continuous survey and this just does exactly what we had wanted to. So that really makes us feel good and happy to see you using this data so intensely. Let's move on to Aparajita. The floor is all yours, Aparajita. Over to you.
Thank you. So let me share my slides. Are they visible?
Yes.
Okay, great. So thanks for inviting me to be the discussant. I enjoyed reading the paper. So let me just first try to gist what this paper does. So the paper looks at a very important research question, which is how demand for healthcare responds to the changes in income of women in a developing country setting. Now, this there is a significant gap in the literature in terms of understanding this question. So I think this is a very useful contribution in that regard. And the paper has a very nice setting in terms of exploiting an exogenous change in income to answer this research question. So as Somdeep has mentioned, they exploit the exogenous variation in the rules of employee provident fund contributions, which has implications on the increased take-home income. I think the paper is very clearly written and it's very interesting to read. And I have a few comments, clarification, and suggestions. Okay. So in terms of understanding, the selection in the samples, so I'll talk about a few things with regards to the various data sets that you are exploiting and, the scope of doing further exploratory work in that regard. So the CPHS data, which is where you use the monthly expenditure on healthcare and other goods and services. I was wondering if you could show some trends, how the real per capita expenditure evolves over time, because in your main estimation framework, and I'll come to that in a bit, as soon as you, I think, put the household fixed effects, I think the post coefficient is getting dropped. But I think it's important to just understand how things are evolving over time. So, if it is the case that, is it the case that it is going up for both the treatment and the control households, where I mean the beneficiary and the non-beneficiary households. And it could be that, the increase or the increment for the beneficiary households is lower as compared to that of the non-beneficiary households, in which case I think you would get similar results. So I think which has implications in terms of interpreting, whether this has, a negative income elasticity in general. Okay, so I think, the rich data that you exploit out of the hospital admin data it's great, and it gives you a very nice opportunity to explore various other channels. So I was wondering, and I think you mentioned this in your talk, that, the patients would declare their occupation, and from which I think you deduct, whether this is formal or informal. And I was wondering if they also record if they have health insurance, because I think this would be typically collected in a hospital setting, and you could, use that to further the understanding of the results. So, one point in this regard is that, as you mentioned, that, women become part of this hospital database once they have certain health conditions. However, I think, there might be differences in the burden of the disease, or at what point in the distribution of the health burden would they seek the healthcare, and that might be systematic to the groups that you are exploiting, right? So it could be that, the formal sector women are more likely to seek healthcare at a lower, health burden, as opposed to, someone from a poor household might just wait for, a higher income or, access to health insurance to take that up. So I think, and since you have data on, pre-existing ailments, and you mentioned eye acuity test, maybe you could just, include a discussion around that, in terms of understanding how this selection into this database is playing out, if there are systematic differences by the beneficiary and the non-beneficiaries in terms of pre-existing ailments and the burden or the intensity of the disease. So I would be using treatment control as, referring to the beneficiary and non-beneficiary. So just telling you that ahead. Yeah, another point I was thinking that, since you talk about income elasticities in eye care, so I was wondering, if we could think of comparing that, and understanding if there are any other studies which deals with computing this elasticity in terms of eye care, because I would imagine, this kind of, there are certain health burdens which you really can't ignore. And even, for, lower class households and poor households. And so, and also on the other side, there is perhaps a max limit, that you can go to. And so if, let's say, if the formal sector employees already have, gone up to that max limit, there's, no more that you can go to with that, increment in their income. Right. So I think just understanding the relevant range in terms of, the response of, take up of eye care in response to and change in income from any other setting would be useful. So I have a few clarifications and comments on the sample. So first of all, you mentioned that you use the sample of households with more female members than male members. And so, and you mentioned very clearly that you are using female majority dominant and only you sum them up, I imagine, and you use all of them. Now, and then you show robustness, for example, for female only and so on. So I was wondering, how are you using age? So are you just, defining the households with respect to all adult members, or, if there are children, how does that play out in terms of the definition that you are working with? So that part was not clear to me. Maybe you can make that thing clear in the paper. So I think, yeah, so another point is, the beneficiary and the treatment group, you mentioned you use maximum members working in the formal sector without any dynamic shifts. And here I'm quoting from the paper, in the pre-shock period. And this part was, again, not very clear to me. What do you really mean by maximum members? And then, without, maybe you can qualify these things further in the, write-up. So I think the table A3 is very useful to understand the selection of the households by treatment and control. So it seems that, when you show some differences in other expenses, it seems that the treated group or the beneficiary group is, they are richer in general, as one would expect. But I think you don't show the statistical significance, might as well show that. So I was, a bit curious to, see this, that it was having higher expenditure in almost all items, except medical expenses like medicines, doctor fees, medical test, and hospitalization. And so, just trying to get the head around, what's happening to, why are these households, who are arguably much richer, are, spending lower on these items as opposed to, informal workers. something to related maybe to the access to, insurance might play a role, and I'll comment on that in a detail in a bit. Then, including the ends, the sample size is useful for all tables, for the beneficiary versus non-beneficiary households. What proportion of the sample are the beneficiary households? So basically what proportion of the sample is the treatment group that you are working with? It is useful to know and, talk about that. As I have mentioned, in the last slide, that they might be seeking healthcare at different points in the health care disease burden, and you can explore that further with your hospital data. And so this is the other point which I'll talk about in a bit, that if the treatment group is systematically different in terms of access to health insurance. Okay, so let me come to the empirical specification which you are using. So some clarifications here. You mentioned you control for monthly variation and you have this delta M here. Now, I wanted to understand, are these just month dummies or month year dummies? For example, is it, February 2018 taking value 1, or, all Februaries are dummy, or are these also taking year-wise information? So maybe you can clarify that. Theta HM, I imagine these are household characteristics that are changing over time. Maybe you can just clarify that as well. Again, I mentioned about this, what is the trend in the health expenditure, because we don't get to observe this beta 2, which I think is, super important to understand. You mentioned you have clustered the standard errors at the household level, which I think is a strong assumption, where you are saying that there's no correlation between households at a point in time, but over time for the same household, the errors are correlated. So maybe you can try clustering the standard errors at a higher level and see if the results are still there. Maybe at the district level, taking into account the randomization exercise as used in the CMI sample. Will be good to show how expenditure on health and in consumption, food and non-food, and you do some of that in your paper, how that evolves over time for the treated and the control groups. As just you show for women, maybe you can just show what happens to men as a placebo exercise. In terms of ruling out alternative channels, so this is, the alternative story that I had in mind, that if non-beneficiary households incur more health expenditure from a higher access to health insurance, where the idea is now once they have health insurance, their ancillary expenditure in terms of, visiting the doctor, expenditure on medicines, that can shoot up, right? It's conditional on the fact that they have health insurance. And this, I have a concern here that, this PMJ, this Pradhan Mantri Jan Arogya Yojana, which actually was implemented around the same time as this PF thing that you are exploiting. It's kind of collinear, it's happening at the same time. So you might say that, okay, now these, control group households have access to some health insurance program by the government, and that is why they are spending more on, health expenditure on these other, seeking treatment. And, as there are existing evidence from RSBY, which finds that out-of-pocket health expenditure goes up post RSBY. Then, seeking healthcare actually goes up. And so does the expenditure, right? And so this is the idea that once you have access, which is again which might be systematic to the treatment and the control that you are utilizing, because the idea is that if this is targeting poor households, which would primarily incorporate, I think, the control group in your setting, if they are getting higher access to health insurance that can just, improve their health-seeking behavior and increase their cost. And so in the DID exercise, you might get, the same result. Yeah, so, I just found this note from a report, and I've mentioned this source here. I'll share the slides with you. So here it says that this funding for the PMJ was, actually to accommodate this increase in expanding the public insurance cost. The cess or the levy on income tax was increased from 3% to 4%. Now, I was just wondering if that has any implications on the salary component, which can just go the other way. And so, one useful thing to actually do, which you already have the data on, is to just show the impact on income from wages, in the same specification as your main specification. Just show what's happening to income, because you have, I imagine, income data. You have a table where you show health expenditure as a percentage of income. So just show what's happening to income in the first place, because there might be these, various things that are going on. So it is, reassuring to see what's the effect on income. Okay. Now, this is from your paper. You say that, these categories they have significant results. It's going down for the beneficiaries as compared to the non-beneficiaries. And in the table which you were showing, actually, I was looking at, the expenditure spent on investigation. I think if you look at the post coefficient, it was going up. So basically, one would interpret it as, for the control group, the expenditure on health investigation is going up. That is of the table that you were showing. And so what is really going on? That could, square up with the insurance story I was talking about. And so, this is the other point which I briefly mentioned a few minutes ago, which is that if the formal sector beneficiaries were already availing, these insurance and, taking the healthcare, then the scope of increase in this group is limited as opposed to the increase in the control group. So, okay, so I thought this table is useful. And here I can see, all the coefficients, including the post. So here, I thought of just choosing one category, let's say cataract, for which the N was the largest, which is, 1,30,000 something. And so if you were to just, interpret these coefficients, so the post is positive significant, which is saying that for the control group, like for the non-beneficiaries after the program, it went up, right? And so, and this DID coefficient, this interaction term is negative significant, but in terms of magnitude, it is definitely lower. So if you have to understand what is the effect on the beneficiaries because of the program, then you are adding this term plus this term, and this would still be positive, right? And so whether that is significant or not, you can test that, separately. So, just by looking at, one very common eye treatment category, cataract, for which you have a lot of sample size, I thought, maybe whatever you are interpreting could be, you might think more on that. Okay. So, yeah, so this is basically, this access to insurance, the PMJ, which was basically assuring up to 5 lakhs coverage for basically targeting the lower income households. And so I think one useful thing which you can do is that there were a few states which are out of this program, I think, as of now. And so to rule this channel out, maybe what you can do is, you can use the heterogeneity in terms of the institutional setup of various states. For example, West Bengal, Orissa, and Delhi they are out of this policy. Maybe they have their own scheme, and you can, account for that and see what role of, health insurance might be playing in this bit of the story. So in terms of the placebo exercise that you have with men, I like that a lot. And I think you could do more with that, which is, where you say, okay, you are looking at male members, considering, only male, majority male and male dominant households. One concern could be still that, maybe there's this sharing within the household, and to just, net that out, you might just want to look at households which do not have any female formal workers. So maybe you can remove them and just look at the subset of households, where the female formal workers are not present, so as to capture. So whatever I've mentioned in terms of the access to insurance stories should also be reflected, I think, in terms of the males exercise. And so I think if you get results, null results in that, maybe you could allude that to your story in terms of this gender bit. But even then, I was thinking that maybe even within the poor households, it could be argued that you see this preference that, okay, maybe I need this surgery, and there's this preference given to the male members, and only after getting funded or getting access from the state health insurance or the government health insurance would the female member go for the surgery or the required exercise. So just discussing that might just help understand what might be going on. And also just show the DID in terms of just show some. I think this table is great, table A5, where you show the pre-post, and you have these key variables of interest. So you could also use the same format and show pre-post difference in other variables like income, expenditure on other items, just trying to understand what's going on, and trying to understand what could be the story here. Yeah, and again, include the ends. And I think, wherever you have mentioned the ends, they were, some tables were showing a lot higher ends as opposed to some other tables. So when you are dealing with a subset, maybe you can mention why there's a drop, in the sample size, and a discussion on that. Right. Okay. Again, this is again very useful. So I like all your appendix tables actually to understand, what's going on with the data and the selection. So I didn't quite understand what this patient category was. So maybe you can clarify that in the paper. And if you have, some patient category, maybe you can make use of that to talk about the selection. Show baseline differences in the health usage bit itself. Why don't you show that? Because I think you have data on that, right? And then you can add a post-treatment difference. You show a pre-treatment, but then you can do that for the post as well. In terms of showing what's happening to other items, that I think is great to understand what's going on. So what I can take off from this table is not very clear patterns, like what's going on. In some items it's going down, in some items it's going up. So while the expense of some items like clothing and footwear, education, hygiene, beauty. And so I was, really wondering what percentage of Indian households would care about, visiting a nutritionist or, hygiene and beauty. So maybe minuscule. So I think, maybe just understanding the ends here as, driving the main sort of result is important. But, other items were going down, like expenditure on restaurants, rent bill, transport, miscellaneous, and other EMI. So I was wondering if you were to fit all these variables in your main specification, and if you still get a negative result, like what would be your story, right? So there are certain items for which you see that it is going down, and then you are talking about, the preferences around health in particular. But then it doesn't seem to be very particular when you look at, the decrease in other items. So maybe just squaring that up, trying to get to understand what's the story behind all this is going to be important. Again, I think you can make use of the male sample as a placebo exercise. And in general, I think this is a suggestion that if you can include the means of the dependent variables in all your regressions, it would help, I think, in terms of interpreting the magnitude of the results as a percentage of the mean. So how big, maybe you could say that this is 1% or 2% or 30% of the mean level. So just to get a sense of the mean is going to be useful from just looking at the regression tables. Okay, so my final thoughts. So I think this is a very highly interesting project and very important research question that you're trying to answer. The project has a lot of potential, and I can see a lot of work is already done. So I think you can explore the data further to understand the general trends in healthcare usage, and maybe you can explore by the type of ailment, at what point in the health distribution are they seeking the treatment, if that is systematic to the treatment and the control group in your setting. Documenting, describing the selection, I think is going to be very useful. And how that impact on healthcare is different from other expenses, such as on restaurants and rents. So what's going on? So I think we need to understand the mechanisms better. And, I'll end at that. Thank you.
Thank you very much. That was a very detailed, very pointed, very substantive set of observations, remarks, suggestions. So would you like to respond to any of them now, Somdeep?
Yeah, I'll just, first of all, thank you very much. These are super useful comments, and please do share the slides with me. I mean, it's very, very useful. And as you rightly pointed out, this is work in progress. And I think these are exactly the things that we should be worrying about. I particularly like the way that, you pointed out some of these issues and also the suggestions particularly. So for instance, when you talked about the household burden, that is something that's really interesting, and we should really explore that, because, endogenous selection is something that will always be a concern, given that we are using sort of arbitrary definitions to define the treatment and the control group. So that's something that was at the back of our mind, but you have really pointed out a very good, a relevant issue there. So we'll have to think about how we can actually address that burden of treatment issue. Also the PMJUI, but you have also shown us the way out there. So we'll try to look at the subsample of the states that were not part of the PMJ and see if it holds. And also for many of the other clarifications, I was making some notes frantically, but we'll definitely try and incorporate all of those. I do not recollect all of it, but so some of them, for instance, yes, we have month fixed effects. So those are not month-year fixed effects. Clustering, as far as I recall, we do cluster at other levels. They seem to work, but because our treatment definition was based on households, we thought that we'll go with the households. But I think it might be interesting. I mean, it might be useful to just have it as another appendix table. So we'll do that. For the ends, yes, I think we should definitely report all the ends. Very interesting thing that you pointed out, I think, which probably we should have discussed more, is that, the control group means are also very reflected based on the standard definitive analysis that we do. And it does suggest that the control group is increasing. So essentially what we are identifying is probably the treatment group is not decreasing as much. So there are we are identifying off differences in slopes. But that again, the insurance idea that you pointed out is very important for us to explore. We do have data on insurance, you're right. But yes, we'll go back and do that. But super useful comments. Thank you very much. And thank you very much for taking time to read it and go through it in so much detail. Appreciate it.
Somdeep, there's a question from Chitralekha, if you could address that.
Okay, yeah. So can income gap or wage gap between male and female households help explain the difference in the income elasticity on health? Since the starting point of income level may vary for these groups, I'm not very sure, because, well, even so, essentially, the identification assumption of our analysis is based on the counterfactuals. So even if the levels were different, what we need to be sure is that in the counterfactual, there would not have been a differential change, essentially. So unless there's reason to believe that this difference would have anyway changed, right? Our identification is not under threat, if I understood your question correctly. So I'd not be very concerned about that. But nonetheless, it might be useful to report wage gap pre and post and see what happens to that nonetheless. So we'll try to do that. I think there's another question by Aposhik which I missed, which is if you classify districts by dowry taking intensity to get a rough measure of patriarchy, do you think we might expect to see heterogeneity? Well, sure, we'll probably see some heterogeneity, but I don't really know how to read that heterogeneity, because again, the issue with dowry is you don't know whether it's actual dowry, whether it's reporting, or whether, you know, or which data to sort of rely on. It might be interesting, but I'm not too sure if that will be very informative for us. But interesting insight nonetheless. Thank you.
Okay. We don't have any further questions. And thank you for answering all the questions which came in the Q&A box, Somdeep. That was very, very nice. And Aparajita has given more than a handful for you to reflect upon. So we will share all these questions back with both of you, and of course the slides. For all the people who sat back and listened to both the presentations, thank you so much. And we'll soon come with more webinars. And this will be available on YouTube. And please go and spread this around. Thank you once again, and have a nice evening.
Thank you. Thank you. Good night.
Thank you. Bye.